Hello, everyone. We hope that you all are excited to be a part of this crucial conversation today. Please use this time to send this link to your friends and family. Feel free to add your questions to the Q&A chat. There will be time for the questions at the end of the panel discussion. During this time, please hold all your questions towards the end of the panel chat. Thank you.
Thank you, Bree. I see people are coming in. Coming in. Love, love, love. Love, love, love. People are coming in. I know. People are coming in. Come on in. Come on in. Come on in. Welcome, 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 welcome. Come on in, come on in. Start in a minute or so. Yep. All righty. Come in. Welcome. All right. Why don't we go ahead and get started? Next. Yep.
Yes, welcome everyone. You have a little bit of an echo here. Okay, perfect. Welcome everyone. I'm just going to go ahead and give you all a brief overview of today's agenda. As you see, we are going to start with a welcome. Then I will go over the California Black Women's Overview and Mission Statement, and then tell you a little bit about our Conversations for Black Women initiative, the reason why we're all gathered here today. And we will then go to Research Spotlight, and we'll hear from none other than Dr. Karen D. Lincoln as she discusses her Listening to Black Californians study. After that, we'll follow up with our panel discussion, which will run about 45 minutes. After that, we'll have time for Q&A, exciting. And just if anyone's joining and didn't hear earlier, the chat will be closed, but you can use the Q&A chat if you have any questions, which will be answered during the question answer period. Then we will go with the next steps. I'll let you know just how you can stay in touch with us, how you can stay connected with the California Black Women's Collective, and then we will have closing remarks. So it brings me so much joy to introduce our President and CEO, Kellie Todd Griffin, as she brings welcome.
Welcome, everyone. I'm so excited about this conversation. I believe this is our third conversation this year. And this is going to be just as exciting, if not more exciting than the previous two. And so I really appreciate and thank Honorable Cheryl Brown, Dr. Lincoln, as well as Dr. Tate for joining us on this exciting conversation that's much needed today. So thank you, and buckle up. It's going to be a great conversation.
Thank you so much, Kellie. It is going to be a very exciting conversation. All right, so let's go over our focus about the California Black Women's Collective Empowerment Institute. If this is your first time joining our conversation or any event, we are a leading 501c3 nonprofit organization that is committed to advancing the lives of Black women and girls across California. Our mission is rooted in driving social and economic mobility, ensuring that Black women and girls not only survive, but that we all thrive. At the heart of our work are three strategic pillars: data collection, policy change, and practice transformation. These pillars do guide our approach to dismantling systematic barriers and building solutions that are rooted in the the lived experience of Black women and girls. We have a Black women's think tank that is housed at California State University in Dominguez Hills. It is the first of its kind that's solely focused on understanding how Black women and girls experience life in California through the lens of gender, race, geography, and we produce groundbreaking research that highlight disparities and reveals untapped opportunities for transformation. It is clear, data shows that to close disparity gaps, we must create intentional pathways to opportunity, and that is why our work goes beyond research. We turn insight into action through statewide advocacy, leadership, development, workforce training, and community convenings that center the voices and needs of Black women and girls. Our impact. Since 2022, the California Black Women's Collective has achieved significant milestones that includes training 596 middle and high school girls on financial planning and leadership, distributing more than 2,500 backpacks, granting over $100,000 to organizations throughout California focused on issues impacting Black women and girls. We've also trained an amazing over 1,400 Black women on leadership, economic mobility, and advocacy. We've honored over 170 Black women trailblazers, and we've produced 32 events highlighting the beauty and brilliance of Black women and girls. We've also convened and engaged more than 25,000 Black females throughout California. All right, Conversations for Black Women. This is about our initiative. The Conversations for Black Women includes informative, resource-rich events and activities that are designed to reset the conversation around issues important to Black women. The initiative includes bringing together subject matter experts, policymakers, business leaders, activists, labor, and community leaders to robust conversations on what needs to be done to help Black women, their families, and their communities on issues that impact their lives, as well as address disparity gaps, develop policy change, and drive practice transformation. Okay, so now we are getting to the meat, almost all of the meat of the conversation, where we're going to get into the data. We know how much we love data. And that is going to be led by Dr. Karen D. Lincoln, who is the professor and director at UC Irvine Center for Environmental Health Disparities and Research. Just a little bit more about Dr. Lincoln is that she is the founder and director of Advocates for African American Elders. She is a distinguished sociologist and social worker. She has over 90 published articles, book chapters, and reports, and is also an active public scholar. She is a fellow of the Gerontological Society of America, a Hartford Faculty Scholar, which is an Encore Public Voices Fellow. She also received her BA in Sociology from UC Berkeley, Master's in Sociology, Master's in Social Work, and a PhD in Social Work and Sociology from the University of Michigan, Ann Arbor. Please help me welcome Dr. Karen D. Lincoln.
Thank you. Thank you so much for this invitation. I'm really excited to be here today. And I just asked for permission to share my screen, and it was granted. So now I can share my presentation. All right. So thank you again for that introduction. And I'm really excited to share this information with you all today. And so these data are part of the commitment by the California Healthcare Foundation to ending health inequity. And so they partnered with Eviderus to conduct a very sort of groundbreaking study focused on listening to Black Californians. So here you see Rodrigo Byerly and Dr. Shikari Byerly, they are Eviterists. It's a Black-owned public opinion research firm in Los Angeles, and they actually conducted the research for listening to Black Californians. They also had an advisory group that was composed of a wide range of stakeholders, including academics, policymakers, community advocates, and providers who helped to guide the study. So the study was conducted from June 2021 to May 2022, and it's one of the largest studies focused on the healthcare experiences of Black Californians to date. It's a 3-phase study to understand Black Californians' experiences of racism and the powerful influence it yields over their healthcare experiences and health outcomes. This project identifies policy actions and practice changes at the clinical, administrative, and training levels that policymakers and health system leaders can take to eliminate the impact of racism on Black Californians' experiences in healthcare and to improve their health outcomes. So phase 1 of the study included 100 Black Californians. They were interviewed about their views on health, their experiences with racism in healthcare, and their perspectives on quality healthcare. So these participants range from the ages of 18 and 86, and they resided across the state of California, and they were selected to represent all Black Californians. And so these interviews were conducted from June to August of 2021. That was phase 1. So phase 2 of the study, it included 18 focus groups, and these included Black Californians as well as key health stakeholders. And they explored the depths in participants' experiences with racism in healthcare, as well as their thoughts about specific recommendations for improving the healthcare system. So these focus groups were held in November and December of 2021. The third phase of the study was a very large survey, and this was conducted with over 3,000 Black Californians across the state. It's one of the largest scale surveys to date focused on the healthcare experiences of Black Californians, and this study was conducted from March to May 2022. So in terms of my study, in 2022, I was approached by the California Healthcare Foundation to dig deeper into these data and some of the findings from the study. So one of the unexpected findings from this study was that older Black Californians were relatively satisfied with their healthcare experiences. And so it was not quite what they expected. And so I was asked to dig a little deeper and to try to understand this finding. And so I indicated that I'd be happy to do that, but I wanted to make sure that the data were strong and that they truly represented the population of Black Californians, not just the people who participated in the study. And so I was funded to look at the study. I looked at the survey instrument, I looked at the focus group protocol, I looked at the in-depth interview protocol, I looked at every aspect of the study that was available to me. And so I shared my findings with the program officer and told her that we needed to strengthen the data a little bit, make some corrections so that it truly represented all Black Californians. And so the condition was I'd be happy to dig into the data and share additional findings, but I wanted to make sure that those findings were truly representative of Black Californians. And so I was funded again to conduct a few studies to correct the data, to make them stronger, and to present data on Black Californians age 45 and older. And so the primary objective of my study was to conduct this new in-depth sort of data refinement and analysis that focused on Black middle-aged and older adults, and to produce 3 fact sheets, and then to disseminate the findings to a wide audience of stakeholders through community engagement activities. And then today's presentation is part of that dissemination plan. So here are 2 of the 3 fact sheets. There is a QR code there that will take you to the website so you can have access to all 3 fact sheets. So I'm going to start with sharing findings from these 2 fact sheets. So the second report that I did focused on Black women. The first report was all Black Californians in the study, 45 and older. But I wanted to focus on Black women. And in doing that, I wanted to also talk about Black men, right? And so it's one thing to talk about and share findings for Black women, but how do we fare relative to Black men? Because I really wanted to highlight the intersectionality of Black women by talking about race, gender, and age. And so the findings that I'll present are a combination of findings from these two studies. So here are some of the key findings. So in the survey, participants were asked whether they'd ever experienced racism or discrimination when accessing or receiving healthcare. So here are the findings for Black women by age. And then here are the findings for Black men. So as you can see, Black Californians report experiencing racism and discrimination in healthcare. However, more Black women are reporting experiencing racism and discrimination compared to Black men across all age categories, with the exception of the oldest age group. So I wanted to be sure to address the question associated with satisfaction that came up when I was initially approached, because it seemed to puzzle the funders as well as the researchers. So I examined the extent to which the level of satisfaction was related to experiences of racism and discrimination in healthcare. And so what the findings showed is that for Black Californians who experienced racism and discrimination in healthcare, they were less satisfied with their care compared to those who indicated they did not experience racism in healthcare. So part of the understanding of satisfaction had to do with whether people were experiencing racism in healthcare or not. And if they were not as satisfied with their healthcare. I also wanted to examine the types of experiences that Black Californians were having during their healthcare visits. And this is one of the hallmark sort of unique factors of this study, is we actually get to see what Black Californians are saying they're experiencing during their healthcare visits. So participants were asked to talk about several negative experiences during their healthcare visits, many of them clearly due to their race and due to their age, with middle age participants clearly reporting that these experiences were more often, that they were happening more often to them. So the first one, I'll go back. The first bar, participants were asked whether their symptoms were taken seriously, right? And we can see that the purple bar represents the percentage of both Black men and women, age 45 to over 75, who indicated that their symptoms were not taken seriously. Okay, go to the next one. They were also asked whether their pain was treated adequately. And so we see almost 50% of participants indicated that their pain was not being treated adequately by their healthcare provider. Participants were also asked whether they were treated with respect. And we also see that Black Californians, many were indicating that they were not being treated with respect during their healthcare visits. And the percentages are much higher for Black people who are between the ages of 45 and 60. So now when looking at these same experiences by race and age and gender, we start to see some differences between men and women, right? So this question is asking about experiences during the healthcare visits, particularly whether your symptoms were taken seriously. So these are the findings for men, right? So around a third or so of Black men are indicating that their symptoms were not taken seriously during their healthcare visits. And these are the findings for women, right? The numbers are very high, particularly for middle-aged women, indicating that their symptoms were not taken seriously during their healthcare visits. So here are the findings for pain, right? Whether their pain was treated adequately for both men and women. These are the findings for men. Many men, a third or more, are indicating that their pain was not treated adequately by a healthcare provider during their healthcare visit. these are the percentages for women. Clearly, more Black women are indicating that their pain was not being treated adequately by their healthcare provider. So one of the unique aspects of the Listening to Black Californians study is that we get a better understanding of what's happening during the healthcare visits. And so participants were asked about certain experiences they had during their visits. Starting from the bottom, you'll see here, they were asked whether their privacy was respected or not. And some indicated, both Black women and men, that their privacy was not respected. They were asked if they were subject to medical harm. Black men and women were indicating that that was the case, that it was true. They were asked whether providers suggested that they were personally to blame for their health problem that they were experiencing. And so you see the difference between Black men and women in terms of whether that was true for them, with many Black women compared to Black men indicating that the provider was suggesting that they were to blame for their health problem. They also indicated that other patients were unfairly prioritized ahead of them, and that providers refused to order a test or treatment that they believed that they needed. And this occurred more frequently among Black women compared to Black men. Whether providers believed them or not. And so many Black Californians indicated, particularly women, 28% of women compared to 19% of men, that providers didn't believe that they were telling the truth. And the most frequent experience was that they were prescribed medication that they did not feel that they needed. And this occurred more frequently among Black women compared to Black men. So I have to admit that, sadly, I wasn't terribly surprised by some of these findings. We know that Black people experience racism and discrimination in healthcare and in other domains. Much of my research focuses on racial discrimination. So it's one thing to know that it's happening. It's another thing to see how often it happens, and then how it's affecting people, right? And so that's key to this study. There are also focus group data that I won't present today, and in-depth interviews that I won't present today, but they are in the fact sheets. And we get to hear the actual words of Black Californians as they're talking about their experiences in healthcare. So this next finding is disturbing for a variety of reasons, the least of which is that it signals to us that Black people take it upon themselves to try to ensure that we're treated with respect, as if it's something that we can control. So here are things that Black Californians do to increase the chances that they will be treated with respect when seeking healthcare. So for some, the pink is women, the purple is men. Some minimize questions and concerns to avoid being perceived as difficult. Some tailored their speech or their behavior to put providers more at ease or to avoid being off-putting. Some took someone with them in the exam room during their appointment to be treated with respect. Some paid special attention to how they dressed. Some signaled to providers that they were educated, knowledgeable, or prepared to hold them accountable. Many, 68% of women and 57% of men, did research on their health condition or concern before they even went to see their provider. So now let's find out what Black Californians are doing to take their health matters into their own hands. So whether Black Californians are engaged in the healthcare system or not, I also looked at Black Californians who were just completely avoiding healthcare altogether because of their experiences. So whether they were currently engaged in the health system or not, they're still taking care of themselves. They're doing things to improve their health and to maintain their health. So out of 12 actions, here are the bottom 3 ways that Black Californians are taking care of themselves, and the top 3. So among the bottom 3, taking herbal supplements or home remedies, this is Black men and women. And so the purple is a great deal, orange is quite a bit, and blue is some. Meditating or deep breathing. So some are engaging in meditation and deep breathing, exercising during your leisure time. These are the bottom 3 These are the least frequent actions that Black Californians are engaging in to improve or maintain their health. The top three: actively trying to reduce stress, getting appropriate screenings or preventive care. Number one, 62%, a great deal, are speaking up about their concerns when they go to the doctor, even when they're not asked by their provider. So now here are the actions that Black women specifically are taking to maintain or improve their health. And this is important to know because their actions are unique, right? And they're not captured if you combine Black men with Black women. So exercising during leisure time, it's not the most frequent way that Black women are working to improve or maintain their health, but they are engaged in exercising during leisure time, working to reach or maintain a healthy weight, taking vitamins or supplements, tracking indicators of personal health or symptoms. So watching their numbers, tracking their numbers, right? Actively trying to reduce stress, focusing on your mental health. This was much more true of Black women than Black men. Praying or engaging in some other spiritual activity. Again, much more frequent among Black women compared to Black men. Getting appropriate screenings or preventative care, and speaking up. Black women are speaking up about their concerns, even when they're not asked by their provider. So finally, participants were asked to suggest ways to address racism and discrimination in healthcare. So here are several of their suggestions by gender. Tying accreditation for doctors and hospitals to improvements in health disparities and ratings of patient experiences, expanding the number of Black community health advocates and or medical chaperones, broader recognition of history and existence of racism in medicine. And I should note, as you can see, that Black women are endorsing some of these suggestions at slightly higher rates than Black men. Increase the number of Black doctors, nurses, and other care providers, requiring implicit bias training by doctors, nurses, and other health professionals, and expanding community-based education on how to navigate the healthcare system and advocate for high-quality care. So the third fact sheet, it's a brief document, it's a couple of pages, it's shorter than the first two. And it highlights just some of the key findings from the first two fact sheets, but importantly, it also includes recommendations directly from Black Californians in terms of what we need to do to address racism in healthcare. So it's really important to elevate their voices. And so with this fact sheet, that's the decision that I made, is to highlight what Black people are saying needs to be done to minimize and eliminate racism in healthcare. So it's important to address those who might identify the barriers to addressing racism based on their suggestions, because these are the recipients of care. We don't often hear directly from those who are receiving care what needs to be done. And so this is a really important fact sheet in that regard. So I really wanted to elevate, again, the voices of Black Californians, and in doing so, also highlight what people are doing, right? Just to really head off those who say, well, this is a really great idea, but it's not something that we can do, right? To actually show that, yeah, there are people who are engaged in ways to minimize and decrease racism in healthcare. And so one of the recommendations came directly from Black Californians themselves, right? Is to expand and support medical education and training that includes curriculum on the history of racism in medicine, the contemporary practices, the things that are still happening that result in disparities and inequity in healthcare and clinical practice, and to work with and in Black communities. So one of the examples of that is one that I can speak to. The University of California at Irvine, their School of Medicine has a Prime Lead ABC, and it's the first medical school program in the United States that's designed to train medical students to serve the unique health needs of African, Black, and Caribbean communities. Also, a second recommendation is to expand the Black health care workforce. This is coming again directly from Black Californians. And to do this through comprehensive pathways and partnerships between predominantly white institutions and historically Black colleges and universities, or HBCUs. And so one example is the UC HBCU initiative. This is an initiative through the University of California and HBCUs, and it provides research internships and funding to increase the pathway from an HBCU to a UC graduate program. And I recently applied for one of these grants a couple of months ago, so fingers crossed that we'll be able to get that and bring students from HBCUs to UC Irvine and train them in environmental health and environmental health disparities. Another example is the Charles Drew University and their UCLA partnership. They have their medical education program, their MEP, that has now turned into a medical school at Charles Drew, right? And also, finally, the Urban Health Equity Pathway at UCLA. It teaches medical students advanced skills in health equity, health disparities, urban health policy and advocacy, as well as the built environment. So these are programs and initiatives that are actually currently working to expand the healthcare workforce that focuses on Black physicians. Another recommendation is to go beyond cultural competency training. We have no evidence that cultural competency training actually results in improved health outcomes. What we need is leadership development, right? To increase the capacity of providers, policymakers, and community leaders to be advocates for social justice and health equity. One example of that is the Satcher Health Leadership Institute. It's at the Morehouse School of Medicine, and it provides collaborative leadership development for physicians, elected and appointed officials, policymakers, community health leaders, and government public health professionals to identify the root causes of disparities. These are people who are working together to find solutions, actionable solutions to improve the quality of healthcare for Black people. Another recommendation. So the current healthcare system doesn't completely need to be dismantled. We're not trying to blow the whole system up. We just want health equity, and we can do that given the current resources that the healthcare system has. There are tools that the healthcare system has at the ready that can be used to improve the quality of care of aging Black Californians and Black Californians overall, right? So just use the tools that are available to improve care. One example is the member level social vulnerability index. We've heard about the social vulnerability index since the 90s when it was developed by the Centers of Disease Control, but it's primarily focused on neighborhoods, finding those vulnerable neighborhoods, right? The COVID vulnerability index came out during the pandemic to find those neighborhoods that were vulnerable to COVID, right? Well, this member level social vulnerability index is for the individual. It's for the patient. It's to get an assessment of the individual sort of risk and strengths in order to provide care based on what the needs are of the patient. And these are things that can be integrated in just regular care, tools that are free and available and easy to use. Another recommendation is to integrate assessments of person-centered care into routine practice. We hear about patient-centered care. And patient-centered care focuses on health outcomes of the individual. Person-centered care considers the person, the context of where the person lives, where they age, where they grow, their family, their community, and their connections, right? And so person-centered care planning is really important. And there are assessments that can be used in healthcare systems to assess the person-centered care environment to better serve the patient, right? And sort of work with the patient's strengths as well as what some of the challenges might be. Another recommendation is to assess the patient-provider communication. Many Black Californians and Black people in the United States, we hear are not being heard. Our voices are not being heard. We're being ignored. We're not telling the truth. And so we can assess the communication between the patient and the provider. And there are tools to do that. Very, very easy to use, very quick, that will put the strength and the power in the patient's hand, where the patient can assess their communication with their provider. And that the results of those interactions could be tied to provider ratings, and can also be tied to the hospital ratings. And we have an example with the Center for Aging in Diverse Communities, where you can download these tools for free and use them to get an assessment of how providers are communicating with their patients and how to improve. So finally, I just want to end with this note, because what we are asking for in terms of Black Californians is not anything more than what we deserve. We just want what's fair, right? We want the same quality of care that everyone else is receiving. And so progress toward equity in healthcare can be achieved by really listening and responding to Black Californians, and by centering the value of person-centered care in the healthcare system. Thank you.
Thank you so much, Dr. Lincoln, for that amazing presentation. And it appears that I'm having a little bit of technical difficulties here, but I am just going to let you all know that what is coming up next is our panel discussion. So I am going to bring back Kellie, Todd, Griffin, who is going to be our moderator for today's conversation.
Thank you, thank you, thank you. Wow, that was great. I took a lot of notes. You know, I was in healthcare on the payer side, on the provider side, and on the policy side for over 15 years. So many of the results that you shared, we saw in motion and lived experience, and just trying to tackle it is always very difficult. And so I appreciate that there wasn't a lot of data on that we could point to when we were trying to make change happen. And so what I love about the work that you guys did with the Disparities, as well as that the California Healthcare Foundation funded, is that we now have data to point to. We now have a source of truth to say that they said, this is what they said that they're experiencing. And so I love that. And I'm very excited about the conversation that we're about to have, just to dig a little deeper. And so we're going to bring back Dr. Karen Lincoln, D. Lincoln, and then we're going to bring in Honorable Cheryl Brown, a former California Assembly member, the chair of the California Commission on Aging, and an advocate for equity in policy and in practice, as well as Dr. Lenore Tate, a psychologist, public policy consultant, expert on behavioral health and aging, and a member of the California Commission on Aging as well. And both Honorable Brown and Dr. Tate are also members of our advisory board here at California Black Women's Collective Empowerment Institute. So welcome, ladies. I see Charles. I don't see Dr. Tate. So I'm sure we'll have that switch soon. All righty. There she goes. Okay. Let's start with Dr. Lincoln. Listening to Black Californians study captured truths many of us live but rarely see validated in data. What was the one finding that personally moved or surprised you, and why?
Honestly, I don't know if I was terribly surprised. I like you, Kellie, you know, we know these data exist. We know these experiences are happening every day. We just didn't have the data in the aggregate, right? To share. And so to be able to have information about what people are actually experiencing during their healthcare visit, right? From the people who are experiencing it, you know, which is key, right? We often get data from those who are providing the care, but rarely do we get data, particularly from Black people who are receiving the care. And so it pretty much confirmed, you know, what we knew. One of the things I have to say that was a little surprising to me, when it came to experiences of pain and being treated with disrespect and not being listened to, that Black women between like 45 and 50 and 65 and 70 were really high, right?
Yeah.
And, you know, there's no evidence or there's no data to really flesh that out. I have suspicions about why that is, but these are interesting age groups, whereby, you know, we have this heightened sort of experience of racism in healthcare at ages where menopause, you know, happens, when we have a lot of pain, when chronic health conditions start to show up, right? Usually around 40, 45 years old, that's when we start seeing diagnoses of diabetes and hypertension, and concerns around our heart, right? And so maybe we're seeing health providers more often during that time. And then once maybe we retire or once we're on Medicare later on, right? And so that's a little disturbing. And we don't know why that's the case, but it's very high. Very high. So that was a little surprising to me.
Yeah, that's my age group. And I know so many of my friends, we talk about it all the time when we're exchanging stories,
Mhm.
you know, like, is this normal? You know, like we, especially those who are going through menopause, we're like, is this normal? Is, you know, my hair is thinning and you know, I'm starting to feel this way. I'm a little more grouchy, you know, and we're like now talking about it more and sharing stories because it was like this unknown. But you know that I will say it's been really interesting. I know that I had a health situation and I just remember a doctor saying, well, it looks like something's there, but that's a normal, you know, that's normal. Everyone has a pituitary glands and it's different sizes. And I go, no, 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 no. It says a pea size.
Mhm.
That doesn't say that it varies. It says a pea size. So, but he was just like discounting it, like,
Right.
no, it's sure this. And it ended up being something really serious, but it was
Mm.
because I pushed back,
Right.
and was calling them at like 2 and 3 o'clock in the morning so that they can get it on record that, you know, this was a problem. But, you know, moving to, Honorable Cheryl Brown, who we've been hanging out with this week. You've always been a fierce advocate for community rooted solutions. Can you speak on like the policy that how has policy historically overlooked Black Californians, our health needs while we're aging, and how we need different interventions from a policy standpoint? And what kind of legislation should we be fighting for when we're talking about holding doctors accountable, finding ways to be in the healthcare system and be viewed differently based on the data that Dr. Lincoln had?
Well, I have to thank you so much, Kelly. Thank you, Dr. Lincoln, and thank you, Dr. Tate, all of you for being here, and the staff, Karina and Charles. I just have to tell you the story about how when I decided to run for office, and that's a whole story that I don't want to get into, but when I decided to run for office, I had people come and say, you know, you're too old.
Mm.
You know, you are too old. And I said, really? Well, what makes me too old? So that was something that I followed all the way through, so that whenever I was still running, when I came to Sacramento to meet with some of the folks that were funders, I should say. And they said, well, you know, you can't win this because the other guy already won.
Mm.
And I went off. So, so I have been disrespected probably all my life whenever I think about what I've had to do. Even with the governor, I had a bill, the bill passed 100% both houses, no problems whatsoever. The governor sent me a message when he vetoed it and said, we don't need it. And it was to study caregiving for older
Mm.
adults. He just said it it wasn't important. So that's the kind of attitude that so many people have taken to especially Black people and older people. Now, how I did that was I went around him and I said, okay, well, I'll just do a resolution. I still made everything happen the way it did. We still got the money from funders. And right now, you hear people talking about older adults and caregivers like you never have heard before.
Yeah, yeah.
So I think you just have to keep pushing it, keep
Yeah.
pushing. There's nothing else I can say about how to make it happen, because I tried policy, I tried, I tried reasoning with people. It just didn't work.
Yeah, yeah. There is no one solution to addressing these really big systemic issues. And first of all, Dr. Tate, congratulations on your appointment as a new commissioner on aging. So well deserved.
Thank you.
And in this role, you're really uniquely positioned to influence statewide priorities. Um, what are some of the disparities that, Dr. Lincoln mentioned that you believe that are really important and urgent for us to tackle, and how are you going to approach that in your new role?
Okay, well, thank you so much,
You're welcome.
Kelly, staff, and Dr. Lincoln. Your data is remarkable, and it's so needed. So I just thank you from both a clinician side, from a gerontologist, from a policy side, and as a grant and for the funders. So, your research, your data will be able to give so many organizations kind of the boost that they need in order to make their case, primarily to in many disparities in healthcare. So I applaud you and I thank you so much. And of course, to the Honorable Cheryl Brown, my sister, thank you so much for the hookup. I'm on the Commission on Aging. I'm enjoying it, and because I'm following in Ms. Brown's footsteps, I'll just say that I have big shoes to fill, but we're going to rock and roll it for marginalized communities. Now, just to answer your question very quickly, Kelly, let me just share this. Behavioral health for not just older adults, but for marginalized communities is a schism. It is big and wide, primarily particularly with Black folks and with older Black folks, and specifically with Black women in behavioral health. We're talking mainly about depression, we're talking about anxiety, and we're talking about cognitive health, dementia, Alzheimer's disease. Those are the three biggies. Okay, so how are we going to deal with that if we have that data and we know that? What can we do? And when we talk about behavioral health, just for the listeners, we're not just talking about mental health, but we're also talking about substance use and abuse. We're also talking about alcohol. So, it covers kind of a wide range. And so with policies, what we need to really do is we have to look at access to care. I mean, access to care, figuring out what the mental health issues are, figuring out access to care, figuring out in our community, I'm going to say this whole umbrella or this whole veil of stigma and mistrust. The stigma comes from kind of an historical perspective. So does the mistrust, particularly in mental health. And then let me just add that I think Dr. Lincoln spoke about workforce development. We're going to have to do something because there's only about 4% of us are psychologists of color, only 4%. So there's got to be a way to train the multitudes, and not just cultural competency, but cultural humility. Because I think there's a difference there, and how that person is able to be received, how that person, I think Dr. Lincoln talked about person-centered treatment, so that we are listened to. And then also, I just kind of want to say, all those social determinants of aging and living longer, whether it's education, social economic status, where you live, work, and pray, has a lot to do with the type of treatment you get and the disparities in data.
Yeah, absolutely. Absolutely. I remember the California Endowment used to talk about that, addressing healthcare regardless of your zip code. You know, how do we lean in? And speaking about that, Dr. Lincoln, around environmental health, which sometimes can be seen like, what is that? Like, why is that so? Like, people have different definitions of environmental health. And we know that particularly in California, it's really broad. But for us, environmental health has historical impacts on, where they build freeways, where where the plane dumps its fuel in those communities. And it could definitely shape our outcomes, especially when we're aging, when we're seeing, older Black people with respiratory illnesses, particularly that live in certain zip codes. What can we do about that? About all of that shapes this kind of overall outcome and the way we live as older adults?
Yeah, and I think your last response about, it's just there's so many factors. There's no one, solution. Honestly, this is something that we hear a lot about, and sometimes I'm like, we need to move beyond that, but we really need to raise awareness about this issue with Black people. And I have learned more and more working with my team, with advocates for African American elders, and that we just aren't aware. There aren't a lot of people coming to our communities talking about, the fact that if you're living next to this freeway, or if you're living next to the airport or near the airport, or, the oil drilling, looking out your bathroom window and looking at the oil drill, right? The ports, if you live near, a port or an incinerator, waste management, right? These industries with all the chemicals in the air. And so the air that we're breathing, the water we're drinking, the ground we're walking on are polluted. And we've seen this more recently with, the fires in Altadena. These urban wildfires are by far the worst. It's not the forest burning, organic materials. It's
Right.
everything that's in everybody's home and cars and in neighborhoods. And the fact that these neighborhoods are so polluted and will be polluted for many, many years.
Yes.
And we're not talking about, what's going to happen to people if they can rebuild, what's going to happen to their health. There's still lead in the soil. It was not just in Altadena, but 10 miles away. We're still seeing really high concentrations of toxins in the air as a result of these wildfires. And so when you have asthma, and you think you're born with it, or because someone smoked, it might be because of where you live and the air that you're breathing, right? If you have gastrointestinal problems, it might be because of where you live. And I think oftentimes we have health problems and we're not linking them to the pollution that affects our brain, cognitive decline. Dr. Tate talked about Alzheimer's disease. It is directly connected to air pollution. It is directly connected to where we live. Our prevalence, Black people, is higher than any group in this country. And it is directly linked to where we live, right? And so I think that just, letting people know that not just where you live, but the products that you're using on your body, in your hair, on your skin, that we're putting on our children, right? That are targeted to Black people are highly dangerous and toxic for us. But there are things that we can do to protect ourselves, right? And I think that's the part that the good news is. You may not be able to pick up and move to another neighborhood, where the air is cleaner and the water is cleaner, but there are some things that we can do to protect ourselves and our family. And those are the things that, I like to focus on when I'm talking to communities.
Kellie, can I just piggyback really quick on something that
And
both
then-
Dr.
and then
Lincoln and Ms.
Honorable
Brown
Brown.
just shared? I also think when we look at, data, behavioral data, Ms. Brown brought up caregiving. One of the things I just wanted to also kind of put a pin in is that we really need to expand access to health coverage. Like that whole, whatever our health insurance is, that whole health coverage that we have, it needs to be modernized. It needs to be expanded so that there's much more of a variety of what we can get for our dollar. And I also want to say that when we look at access and kind of advocacy and policy development, we could do a lot more with telehealth, particularly to reach those like us.
Mhm,
And so I just
mhm,
kind of wanted to share that in terms
mhm,
of that health coverage.
Kelly,
mhm.
there's a couple of bills. There's one bill that talks about, well, let me see, what's his name? He's from Los Angeles. He's in the assembly.
Isaac Bryant.
Isaac, yeah, right.
Yeah.
Isaac Bryant
Assemblymember
has,
Bryant.
right,
Mhm.
he has a bill that he's trying to get passed so that he can well, I guess they already pass that? Because he talked about it at our meetings up there in Sacramento. And what is happening is those oil fields in LA,
Yeah.
they were causing a lot of problems. So now he's making a deal or working with the companies to make them come up with a fund that they have to pay into $20 million a year for so many years so that they can take that money and try to help clean up some of the issues that the oil fields have created.
Yeah. Yeah.
But there's so many other places. I think about the fires that were caused by Southern California Edison. Now we're going to have to pay for their fire. And we live in San Bernardino.
Mhm.
So there are things that when you're looking at policy, but we have to be advocates and we have to tell our legislators what we want. So that whenever people come to them and talk to them about whatever, that they come and they say, well, how does that affect the African American community? Or how does that affect Black people? And I don't mean the Black people who were elected and up in the legislators. I mean the ones, everyone. White people have to be able to say it as well. I think that's a problem.
Mhm. Yeah, and we know that not all Black Californians are represented by Black caucus members.
Right.
And so it's important to educate all policymakers.
Mhm.
Dr. Lincoln, you've said before that data is a tool for justice. We need to get t-shirts that say that. I usually say, trust in God, everything else need data, but I like that data is a tool for justice. How do we ensure that the data that we're collecting about people leads to action and doesn't just sit on the shelf and become another academic report? We see that oftentimes, and it doesn't get to the people who really need to know what the stories that are being shared.
Yeah, I think this forum is an opportunity to do that. I mean, I could have just written the fact sheets and been done. And just, they're on the California Healthcare Foundation's website. But part of what was really important to do is to share the findings using webinars, and we do it in person. We were in Riverside a couple of weeks ago, and everywhere we go, we talk about this work to make sure that it's in the hands of people who need it. When I was talking to the funders, I said, they said, who are these fact sheets for? I'm like, they're for Black Californians.
Right.
And that's how it's written so that it's accessible. So I think the extent to which we can take our work and advocates for African American elders, I should say, one of the hallmarks of the work that we do is we share our work with the people who participated in our studies first. And so they're engaged from the very beginning all the way through dissemination. And so I think the culture of research needs to change, whereby it's not ivory tower and, researchers talking to researchers. It's research as service. And I think it's really important for us to remember why we're even doing this work. And I'm very committed to supporting our communities. It just so happens that I have access to research. And I make sure that, you know, the same tools that I have, that our communities have those tools as well. And so, you know, the extent to which we involve the people who are most affected and the least engaged in the work, it will definitely fare us well to get us closer to equity.
Mm-hmm. Absolutely. Honorable Brown, in that vein, how do we, you know, we just finished our Ledge Day Monday, and with knocking on the doors, and we had, you know, all these groups there all at the same time, everybody speaking up for their issue, with the lens of Black California. How, but you also know there's a lot of institutional resistance to creating policy for Black Californian. And what's used often is Prop 209 to say, can't do it. And you always have to remind them, well, no, that's education, public contract, and public employment. Right now, we're talking about healthcare. How do we navigate that? And how do we push back when we are trying to get this kind of equity-driven legislation?
I think we all need to come together. All those organizations we had up in Sacramento, everybody's talking about something different.
Yep.
I got up, I said, well, where are you talking about seniors? I said, we have to talk about what's going to happen whenever all these people have to be cut off of Medi-Cal. They're going to have more homeless. They're going to have more problems because of what the federal government is doing, what Donald Trump is doing to put us out the pasture, more or less. So we do have to all have to get on the same page and find out what is the most important. Now, when I came into this process with the master plan for aging, the first thing they did was, oh, I want to tell you about my program, and I want to tell you about the legislation I want you to support. And I raised my hand and I said, hey, let's stop it. Let's stop it. We can't do this because we'll get nothing. Nobody will listen because there's too much out there.
Too many voices.
I think the thing we have to do as Black people is to come together and say, these are our issues, and just do no more than 5. And we can work on that by talking to and having focus groups that can come up with, okay, what is your top issue? Because I saw where NAACP had so many issues, and BAPAC was me, so I I did the senior issue, but there's just we're too fragmented as Black people. And like you said, we don't all have a Black representative. I don't have the first time in 50 years, I don't have a Black representative. Ridiculous.
Right.
So
Right.
I think we have to come up with a process and a program to make that happen.
We have to have a master plan for California.
Right.
Right. For Black California.
For Black California.
And then we all take a part that is where our specialties are, right? So if I'm talking about economic mobility, then I speak on that, but it all ties back to that master plan. And speaking of a master plan, go ahead. No, sorry.
I think that's excellent. And there's just a way to do it. It takes a few years, takes a little bit of time.
Yeah.
But we can do it.
Yes, absolutely.
We just need great leadership like you, Kellie.
All right. And speaking of that, master plan, Dr. Tate, oftentimes, you know, and we see it a little bit, you know, like I said, I've been in healthcare for a long time. And oftentimes we'll say physical health and focus so solely on physical health. And in recent years, we started talking about the integration of physical and behavioral health, but it still seems to be like a disconnect, particularly when we talk about Black people, because they don't see it from our lens, right? Our cultural lens of to what you mentioned earlier around, we just don't want to talk about that we may be having some issues. How do we take the data around behavioral health and the experience, not just the quantitative, but the qualitative data, and humanize that and advocate for, Black Californians around the behavioral health and in the intersection of aging? Because I know that Karen Bass, the mayor of Los Angeles, said that the largest group of unhoused in Los Angeles is
Yes.
Black women aging into being unhoused because they're working poor.
Yeah.
Right? They're working poor through their lives, and then they no longer can work and find themselves housing unhoused, and it's some of the mental health things that maybe were suppressed, and now they're finding themselves on the streets in the largest city in the state. So how do we get ahead of that more upstream instead of, seeing the crisis downstream? Like, we didn't know they were working poor. They were dealing with so much being working poor, and then all of a sudden they just break.
Well, that's
One of
probably the $64 million question, but let me just answer you or reply by saying give you a couple of notes. First of all, I just, and I'm not sure about my data, but I think 1 in 5 older adults are homeless or unhoused. 1 in 5 older Black adults. That number is steadily increasing. So oftentimes, this is just my opinion as a former policy person, oftentimes policy comes as a reaction to. So it's not ahead of. Okay, so, we've got the data. Now what? How are we going to turn that data and these findings into even a pilot program? And one of the unique ways to do that is through storytelling, putting a face with the data, because we know the power of storytelling and the power of when you see someone share their story about being unhoused, share their story about depression, share their story about menopause, share that story about the misdiagnosis, share that story about how I wasn't able to get to the doctor because I didn't have enough money in the buses don't run in my community. Share the story, get into focus groups, bring the stories, bring the data through stories to your community, to your elected officials, to your town hall meetings. And I think that once we make the data personable, we begin to see much more of kind of a grassroots fire that comes under many politicians in terms of getting policies done. One of the interesting dynamics that I experienced just working in both the Assembly and the Senate and as a lobbyist is if you can make it personable. It used to be, if we could find out whose family member was having problems with caregiving, whose family member was misdiagnosed and they had a heart attack, whose family member, has comorbid issues and their insurance is not taking care of it. That is really a powerful tool, if you will, in order to increase access, particularly to those that are most vulnerable.
Yeah. Yeah. And there was this young lady who did a TikTok. She had an experience at a community resource center that 2 health plans have in LA, and walked in, and she didn't speak, that they were doing a class only in a language that wasn't hers. And when questioned, that the response was culturally disrespectful. This is a Black woman.
Mm.
And she went on TikTok
Yeah.
and
So
she
Kellie,
started talking about it on TikTok, and it blew up. And
let me just share this, because this is a real good example. And I'm it's kind of gloom and doom, but I just kind of want to share this example. So for example, it has been my experience that in our community, not only do we not talk about mental health, but we definitely don't commit suicide.
well,
Can I drop the mic on that?
yeah,
And especially our children. But what we're finding out through data,
yeah,
okay,
that's
through
not true.
data and storytelling is that suicide among Black youth
Mhm.
Yeah,
is exponentially off the chart.
yeah,
Mhm.
But
yeah,
if we didn't have the data and we didn't have the mamas, the daddies, and the brothers and the sisters to talk about it,
yeah,
how are we going to get money for intervention at either the primary, secondary, or tertiary level? And let me just say one last thing, and then I'll move on, and then I'll shut up. But through Proposition 1, that's the new behavioral health transformation bill that was passed in 2024 and signed by the governor. There's going to be goo-gobs of money, excuse my
yeah,
expression, but hundreds of millions, if not billions of dollars that are going in to fund new innovative programs, not only for youth, but due to Ms. Brown's advocacy to older adults too,
yeah,
and those that are marginalized.
yeah, yeah,
And another thing, you have to always, you have to have a framing. One of the things whenever I went into the assembly is I would say, there's going to be a silver tsunami. And if you don't do what you're supposed to do, that silver tsunami is going to hit us, and it's going to hit us soon. Now that was less than 9 years ago. And right now, that silver tsunami, I went to the Capitol yesterday and or Monday, and they said, "Oh, here she comes. You remember the silver tsunami, Miss Brown?" I was on the floor, and they're still talking about it. You have to get a hook. I don't care what the advocates say about how it makes it so. Oh, it sounds like it's so bad for seniors, and they're in such dire state. Yeah, but you have to get a hook to get these people to understand what the issue is. And
yeah,
I like what you said, Lenore. You have to. You just
yeah,
really.
yeah. All right, Dr. Lincoln, the strength of this research is off the chart. What are you hopeful for? Where do you see the greatest opportunity for us to disrupt inequities through both data and the community power?
Huh. Well, I think, to start off with, just to start where we are and to say that, the California Healthcare Foundation funded this work. Can you imagine? They funded a study focused on Black people's experience of racism in healthcare.
Yeah,
And so I think that is a testament to a lot of work, that is ongoing. And, I'm a social worker, right? As well as a sociologist in public health. And I work in communities. I tell my colleagues, the community is my lab, and a lot of us are doing this work. Most people don't know that there are current ongoing initiatives in our communities. People have been doing this work for a really long time.
yes,
And I have to tell my students that environmental racism, that term was coined by a Black person. Do you understand the environmental justice movement was started by Black people, right?
yep,
And that's not what they're being told, or that's not how they're educated. So we've been doing this for a really long time. And even with the current climate, you talk to some people. I mean, if my grandmother were alive, she's like, this is nothing compared to what she's been through, And so I think that there are, great examples out there of people doing this work. The fact that I was able to, in that third fact sheet, identify people who are doing work. Not just saying, oh, I recommend we should do these things. People are doing, this work. And so my hope is to shine a light on, those who are doing this work, who are doing it well, and who are making a difference, and who are really focused on, our communities. They may not get the recognition, they may not be highlighted, they may not be, well funded like other research, but they are out there doing the work. And so my hope is that by just shining light on a few of these examples, that more people can feature and highlight, the people who are doing the work in our communities, because we really need that hope. We
Yeah.
need to know that people are out there working for us every day, whether we
Yep.
see them or not. And to what Dr. Tate said, I was leading the homeless count back in 2016 with Dr. Gaines and Miss Mardell and Miss Maxine Toller, who were probably on the call. And we were out there across the county in Los Angeles, collecting data, talking to unhoused people. And I actually said that, the older population, particularly Black people, right, we're most vulnerable. It's one normal event that happens. You get divorced, you break up with your spouse,
Lose your
a family
job.
member dies, your hours get cut,
Yep.
not even lose your job.
Yep.
The
True.
overwhelming majority of people who were homeless for the first time
It goes up.
was because of that one. It wasn't drugs, it wasn't mental health. It was
Nope.
all around social relationships. The overwhelming majority, it was social, but we're not talking about that. So I think there is room for stories.
Yeah.
But data don't lie. The data are there. We just need to use it. So I think if we don't collect another piece of data, I think we have enough for real change.
Yeah, I totally agree. I said I just graduated high school and became unhoused. I mean, it's something as simple as that, right? You graduate and you're out. Many foster youth experience that every year. The other thing is I'd be remiss if we didn't talk about these types of partnerships that are so critical, because that is the strength is in the numbers. The fact that we are been partnering with all of you on this call. I'd be remiss if I didn't mention this California, the Budget Center for Budget and Policy that has been crunching numbers on Black Californians for us, and nobody even knows that they're doing it, right? They have just been crunching and producing reports around Black women. We're about to release a report next week on just Black women and their impact on the federal government, that the ones on WIC, the ones on SSI, the ones on CalWorks, and that impact of these cuts and what it's going to do, or the Bunch Center that's working on Altadena, Blacks in Altadena, and the impact of those fires. I mean, there's a lot of phenomenal work together. And to Ms. Brown's point about how do we come together and make sure we're speaking all in one voice, and putting it in front of these policymakers that oftentimes one of the assembly members texted us and said, "You guys, we loved you having here, but you guys your voice wasn't as loud as the folks that were on doing anti cuts to the the cuts to Medi-Cal for immigrants. Like, we needed you guys to have a strong, loud voice. And so how can we circle back and get that to us so that we have something to stand on the floor when they're trying to cut the things for Black Californians, just as our counterparts have when they're talking about immigrant health." So I want to just ask you all this one last question. And I think you've already, many of your responses, but what is the last solution that you want to just add to make a difference, small or big, in advancing health equity for Black Californians?
I think I already said it, is that
Yeah.
we need to get on the same page. Let's do what you said and do a master plan for Black people. And I
Let's do it, Miss Brown.
I think I have a little bit of experience.
Right.
If we can do something like that, we have to make sure that we look at it with Black men as well as Black women, as well as our older adults. We can't separate
Yeah.
and divide ourselves like that. So I think, and I don't know about, I do hear people talk about folks that are not citizens. And I don't know how to put that in with Black people, because Black people have their own ideas. We've been here all these years. We've been here forever,
Yeah.
built the country. And whenever we go and add other people and dilute it, what happens is that we always get cut out.
Yeah. But we have Black immigrants too. So
That's fine, but I'm just saying, I'm talking about Black people, period.
mm-hmm.
But some immigrants think that we should include all immigrants in our issue. And I don't know if we can do that and be successful.
Mm-hmm.
That's all. I'm just telling you what I feel.
Understood.
That's all.
Dr. Tate.
Yeah, so I think that it's a dynamic process. I think it's a complex process. I think it's a collaborative process.
Right.
And I think that we've talked about how we might come together to kind of forge our own kind of policies that are our top 3 or 4 or 5 wants.
Mm-hmm.
But I really feel that we cannot be fragmented any longer. But also, you know, I'm going to kind of speak kind of from soft skills. We need empathy for each other. We need respect in addition to collaboration. And that's throughout the ages and throughout the diaspora and throughout the whatever else separates all of us. So that's kind of my last words.
Beautiful. Last but not least, Dr. Lincoln.
Yeah, well, just to add, I think, your voice matters. Each and every one of us. And for anyone who feels disempowered or disenfranchised or ignored, your one voice matters. And just with this study, could you imagine 3,325 Black people
In California.
in California shared their experience in the survey, not to mention the 100 interviews and the 18 focus groups. People had something to say, and here we are talking about it. Right?
Yes.
And so I think it's really important for us to remember that regardless of our circumstances, your one voice matters, especially when it's joined with other voices. And so I encourage all of us to speak up and speak out and do it often.
Yes.
And, let me just kind of buttress that. Doing it often, not just when the crisis happens, but let your local leaders hear from you. You can go to this Capitol, but local is global. Okay, so if you keep the squeaky wheel, as one of us said earlier, gets the grease. But local is global, so continue to speak, continue to advocate.
Yeah. And I'll just add and continue to ask. Because one of the things we found in our research is the open-ended question is, what else would you like to share? And without question, they say, thank you for asking. So I want to thank you guys for the work that you're doing, and thank you for asking the questions that are important to Black Californians. Because without this, we wouldn't get as far as we can and faster. Your work helps us get further faster. So thank you, Honorable Brown.
Let me just add one thing.
Yes.
I neglected to say, we have a robust Black press in California.
Yes, yes.
And we really do need to, first of all, respect that Black press more. And we need to use it. And we need to make sure that we are a part of reading it and being a part of it.
Yeah.
So the Black press is still probably the only thing we have left that's cohesive, that talks about Black people and they're not ashamed to talk about Black people.
Yep. All right. Well, thank you, ladies.
Thank you.
I hand it back over, I believe, to Miss Karina. You're on mute.
And now unmute. Hi, ladies. Thank you so much. Thank you, Kelly, for moderating. This was such a wonderful conversation listening in. I was sitting down taking notes. I know that we do have some audience questions that have come through. So I am just going to start those as they came in. The first ones are questions for Dr. Lincoln. Were participants instructed to reference a particular type of healthcare setting in their reflective responses? For example, outpatient care versus inpatient.
Yeah, thank you for the question. So, no, patients were not asked the specific context in which they were provided care. And I really encourage anyone who might be interested in the Listening to Black Californian study to go to the California Healthcare Foundation's website. You can actually see the study as well as the survey and reports from the study. And so, yeah, we don't know exactly where people were receiving their care. The question that was asked was where they received their main source of care, but we don't know if it was a hospital or a clinic or, outpatient or inpatient.
Okay, and there was a part 2 to that question, and that is, did participants' responses or perceptions appear to differ based on their insurance status? Example, private insurance, Medicare, or Medicaid?
Yes. One interesting finding that's in one of the fact sheets is that for Black Californians who had public insurance, like Medi-Cal or Medicaid, they did report more experiences of racial discrimination compared to people who have private insurance, but that was only to a certain point, right? In certain instances, it didn't matter whether participants had private or public, they were reporting very similar experiences.
Okay, thank you, Dr. Lincoln. This next question is open. Given some of the implicit and unconscious biases with some doctors, are there processes for Blacks who are not aware of their options when they feel not heard, respected, or seen that can be distributed through a grassroots effort? So anyone, I feel like, or
I'll start.
okay.
And then maybe some of the other panelists can pick up. So basically, when we talk about implicit bias, we're talking about those decisions that affect your well-being through your doctor's kind of feelings, if you will, on judgments and stereotypes that he or she has of you, whether it's your ethnicity or your gender or whatever else it is. And we see those particularly, like, for example, in women, you might go in and think you might be in menopause or post-menopause because you're sweating or you're out of breath, and you could be misdiagnosed because of the judgments or stereotypes that your doctor has about maybe women at a certain age, and kind of shuck off, if you will, it could be heart disease and test you for that. And so I just think that we as humans really need to be our own advocates. I think one of Dr. Lincoln's data points showed that many of us, or many women, go to the internet first to look at possible symptoms that we're having. And Dr. Lincoln, correct me if I'm not speaking correctly. But so do your homework a little bit first. Have a set of questions. And if you really feel, even as Kellie had shared, that there might be something abnormal or unusual that's happening or you're experiencing, you really have to be your own advocate. Really, or bring someone in to really advocate for you.
Thank you, Dr. Tate. Did anyone else want to add on to that response?
I'd like to add one thing. So, part of the Affordable Care Act includes a section on discrimination in healthcare. And I think, one of the things that I wrote in the fact sheet that's specific to Black women, I call it triple jeopardy because they're Black and women and they're older. I talked about how important it is that healthcare providers make sure that every patient understands what their rights are when they're experiencing discrimination during their healthcare visits. That's something they should be handed every time, because there are, within the state of California, civil rights support so to ensure that, we're receiving fair care. And if you are violated, if there's a discriminatory act, that's a violation of the law, right? And there are ways to file lawsuits. And the more recent revision of one of the sections of the Affordable Care Act doesn't just, it went from you having to file a lawsuit based on racial discrimination versus gender discrimination versus age discrimination versus gender identity. It's all one thing now, right? You don't have to file separate lawsuits. You can file one lawsuit if you are being discriminated based on your race, your age, your gender identity, or your gender. And so I think knowing what your rights are is really important. I don't know if we are aware that as healthcare recipients, as patients, you do have rights, right? We may or may not be aware of those rights, but we do have them, and there are people who are available to fight for us.
Thank you, Dr. Lincoln. Armour Brown, would you like to add anything?
No, let's go to the next question so we can get all the questions answered.
Yes, we have two more. The next question is there any data over misdiagnosis or over medicating?
Yes.
Okay.
I'll give you an example. And Dr. Tate, you please weigh in. So I'm a mental health disparities researcher, so mental health is kind of my thing. With Black men in particular, severely underdiagnosed with respect to mood disorders like depression, overdiagnosed with schizophrenia, despite not having schizophrenia, and certainly undertreated. And in many cases, as a Black people, both male or female, were overtreated. But yeah, there are data to indicate that we are often underdiagnosed, misdiagnosed, overdiagnosed, undertreated, and overtreated. And that has a lot to do, as Dr. Tate mentioned. I mean, there are a lot of factors, the least of which is that there just aren't enough Black care providers who are trained to actually diagnose us appropriately. But yes, there are definitely data that indicate disparities with respect to diagnosis and treatment.
Dr. Tate, you're on mute.
Just real quick, again, I would say yes. But this is why we're talking also about there can't be enough of us's right now. There aren't enough psychologists. There aren't enough mental health therapists, professionals right now. So the alternative is not only cultural competency, but cultural humility among health professionals. Like if I come in and I'm 65 and I'm sweating and I'm having heart palpitations, and you're going to tell me your blood pressure is normal. It's okay, maybe, just take it easy. And it keeps going on and on. I go back 5 or 6 times. Cultural humility comes in. It says, well, wow, let me triage this in my mind if it were Queen Victoria. Maybe she needs an EKG. Period. Because see, we're trusting. Some of us are trusting. The others are mistrusting, so then they're not going to even go to the doctor. Okay? So, we've got that schism in our culture. So I'm just saying, we've got to advocate for ourselves. And we've got to find those docs that have humility.
We may need to teach people how to advocate for themselves.
Yeah.
That's another thing, because they don't want to be disrespectful. They really are respectful of that title, doctor, and they don't want to be disrespectful, but we have to teach people how to do that. Now, I had an opportunity when I took my husband to the doctor a few years back, and the doctor was trying to tell me something crazy. I just hit the table and I said, "You're not going to talk to me that way." That doctor did get fired, by the way. But but he didn't respect me, and he didn't respect my husband.
Mm.
So I probably overreacted and scared him to death. But we have to teach people how to fight for themselves without being offensive.
Thank you. Thank you, Honorable Brown. Thank you, everyone. And okay, let's see. Let's move right along because the questions are coming in. Let me see, make sure we can get everyone in. Let's see. I appreciated the long-term solutions. I'm wondering what are some in the moment at the point of service recommendations for one experiencing racism?
I don't think I understood that question.
Basically, they're experiencing racism in healthcare. What should they do? Find another doctor.
That's one thing you could
That's
do.
one thing. Move on.
But Karen, Dr. Lincoln said that you can file a charge. You can file.
Yeah. But in the meantime, you better find someone that can help you. You can move on and get discharged. But the problem is in our healthcare system, and Dr. Lincoln, you may be able to respond to this. The problem is if you're low income and you're at a particular clinic and you experience racism, how long do we have to wait? Months to get another doctor at another clinic.
That's true.
This is not Disneyland. It's not difficult to navigate that.
It is, and one thing I will add, and what you're saying both is correct. I think one of the things that I have to sort of I talk to my students about this. I never want anyone to leave a situation feeling like they should have said something. Because you go home and you lose sleep and that person is sleeping well. So if you are experiencing in that moment, if you believe that you are being discriminated against, that person has a boss, right? That you can speak to. And it's no different than if you experience something in a grocery store or a gas station or a department store. I mean, these are people who are there to serve you. And if you don't believe that you are getting service that is fair, then you talk to their boss. You have every right to ask to speak to a supervisor, right? And you also have every right to complain. And I will tell you, no healthcare provider wants to have a complaint being submitted because of the way that they treated a patient. I mean, that is a powerful tool that all of us have access to. And so you can address it immediately with the person providing care, as well as who they're accountable to, and to file a complaint as well.
I did all of those. And they did get fired.
There we go. We have the results of following Dr. Lincoln's recommendations. Thank you, Honorable Brown and Dr. Lincoln. Okay, so this one is thank you for the educational forum, and it's been very enlightening. As the founder of ZAMBI, and forgive me if I'm mispronouncing, but it's the National Organization of Black Lesbians on Aging, a 501c3 nonprofit organization for Black lesbians 50 and older, centering on education, advocacy, and community action research. The question is, are there plans to include specific research questions going forward on Black LGBTQ older adults who are most vulnerable?
Well, I'll just speak to the Listening to Black Californian study. There are not only questions in the survey that are specific to LGBTQ+ communities, there are focus groups and in-depth interviews that are specific to LGBTQ+ communities. These are Black Californians. And there are also reports from the Listening to Black Californian study that are specific to LGBTQ+ communities. So there was intention on the part of Eviderus to focus on the heterogeneous population of Black Californians, and that includes those of different and varied gender identities.
Yeah.
Can I say that the California CCOA that Ms. Tate Dr. Tate is a member of now, have put that as one of their agenda items for this year. And that study has now gone into, it's in the works.
For policy
And
development.
that's for all LGBT plus, not just Black, and I don't know how they broke it down, but it's a really big study and it's the first time it's ever been done. And the person who is the person who did it, who really advocated for it for years, she's been advocating, and that's Dr. Marcy Edelman. And that study is I'm sure that it's out now. I'm not in the Lenore replaced me, so I'm not there anymore to see what happened with it. But I understand that it has come to fruition.
Okay, thank you. And I will just make this, they did say that the ZAMI NOBLA conducts a community-based research, and they have a number of peer-review articles on their website, and I'll be sure to include that in the post materials. Okay, so we are going to get ready to wrap up. I'm going to ask one more question. And that is going to be, it says the panel touched on data with mental health in situations with misdiagnosis when it came to mental health. But are there any specific further data specifically with implicit and unconscious biases?
I'm sorry, can you repeat that question?
Sure. They said the panel touched on data with mental health in situations with misdiagnosis when it came to mental health, but is there any specific further data specifically with implicit and unconscious biases?
So if I'm understanding the question correctly, I can speak to the Listening to Black Californians, and there's no data specific to that study. I think part of it had to do with the fact that it was not asking providers, it was asking Black Californians in terms of their experiences. I will say that in terms of the recommendations from the participants, increasing or actually mandating training on implicit bias was one of the recommendations that they suggested to address issues of racism in healthcare. But the specific conversation around implicit bias is not a feature of this particular study.
Thank you. Thank you. Thank you, everyone. Dr. Lincoln, Dr. Tate, Honorable Brown, we appreciate you joining today's conversation. If there are any unanswered questions, if it's okay, I will send them to you guys, you ladies, excuse me, just to see if we can answer them offline just for the sake of time. But this has been an amazing panel, amazing discussion, enlightening discussion. And we thank you. We thank you so much for joining us today. Did you all have anything else that you wanted to say?
Thank you very much. And especially, Dr. Lincoln, you have put us on the map. You have done such wonderful work, and I appreciate it. And Dr. Tate, you know you are the person that does this and continues to do it. And I am so happy to be a part of what you do. And Kellie, Todd, Griffin, thank you for inviting me. Thank you for including us. And thank you for paying attention to this particular subject as it relates to Black people.
Thank you, you guys. This has been a great conversation. I know Karina has some more remarks, but thank you guys. This was really great. Now I have to sit there and think, okay, now we've committed to doing this master plan. Now I got to figure out when, where, and how.
Yes, that was a comment as well. Let's do it.
Right.
Somebody said, let's do it.
Yes, let's do it. Right.
First of all, you have to get the money to do it.
Yes, exactly.
That's a real issue when it comes to finding this kind of information out. But if you can get the funding, then I don't think it would be real difficult. And if we have Dr. Lincoln, who can really be the anchor for that.
Absolutely. Absolutely.
Thank you. Thank
Alrighty.
you. All right. Yep. I am going to thank you all again. I am going to move forward with our next steps. Perfect. Okay, so our call to action. You are always welcome to join the conversation. You can join us for powerful workshops, panels, and discussions that are designed to inform and uplift. And we also would love for you to spread the word, and we will be sharing in our post-event materials how you can sign up and continue to be a part of the conversation. We encourage you to amplify our legacy, help by helping collect and share powerful stories of Black women across generations. Then you can be the change. Advocate for authentic representation in media and society. Support our campaigns by volunteering, donating, or partnering with us to uplift Black women everywhere. And then there's always, after advocating, educating, and empowering. We can bring our educational outreach programs to your school or organization or community, and there will be access to that, to be able to do that in our post-event materials. And just a huge thank you to everyone who has joined today's conversation. We so appreciate you, and we thank you, and we look forward to the next conversation. Bye. Thank you all again for joining.